Very good. I'm Dr. Gregory Jicha. I'm a professor of neurology here at the University of Kentucky. I've also recently been appointed as the medical director for Kentucky Telecare. I've been at the University of Kentucky for 8 years now, and shortly after I began here, I was contacted by the Kentucky Telecare network staff asking about a patient that lived in a rural, remote area of Kentucky, several-hour drive, and this patient was very comfortable in their own community, but quite uncomfortable traveling to Lexington, which is often considered the big city. I chuckle at that coming from New York City, but nonetheless I can appreciate that concern from folks living in discrete areas of the state that aren't comfortable with that kind of travel. Of course, traveling many hours in a car with someone who may have a moderate or severe dementia in and of itself can be an impossible task. Using telemedicine, we can reach out across the state. Now, I had never done anything like this before, but I'm always open to new ideas, so I decided to give it a shot. I sat and met Miss Mary Horsley, who had previously not been diagnosed with a memory problem, but it was quite clear from our evaluation that she was in the mild stages of Alzheimer's disease at that point. That was nearly 7 years ago, and really was a launching point for the telemedicine memory program here at the university. I cared closely for Mary over the years, meeting with her every 6 months via telemedicine, sparing her any trips to Lexington, and was able to provide not only diagnosis, but full and complete care throughout the course of her disease until she eventually passed a little over a year ago. It was an experience for me evaluating patients for the first time, and I began to scratch my head and think about the possibilities, not just for this one patient, but for patients across the state that may be in similar situations. I went back to my clinic and began analyzing my actual face-to-face evaluations, thinking about how much time do I actually lay hands on a patient versus how much time am I testing their memory and thinking abilities and running through a history. And what I found was that actual physical contact was a very minor part of the entire evaluation. I then began to think about ways that I could visually test and or use remote staff to gather that same information. We applied for a research grant through the Alzheimer's Association and were funded for 2 years to actually work the bugs out of that system. We were able to validate the telemedicine encounter versus a face-to-face encounter across the board with astronomical correlation and significance. The two evaluations provided exactly the same information. The only discrepancy we found was rather unique. We did have a patient who, in a face-to-face evaluation, was diagnosed with mild cognitive impairment, mild memory problems. There were no reports given of any kind of functional decline or impact on their daily life. And yet, via telemedicine, the family seemed actually much more open to discuss some of the real-life functional disability this patient was experiencing that shifted that diagnosis into the realm of dementia. And again, had me scratching my head as to whether or not use of the video system actually allowed people to feel somewhat safer in divulging personal or private information. It was counterintuitive to me, but I found that fascinating. We also have been able to use the system not only to provide clinical care across the state, but through our research program to begin to investigate specific risk factors for dementia that we think are responsible for the earlier age of onset for degenerative dementia in rural areas, approximately 7 years earlier for the onset of a disease like Alzheimer's, 5 to 7 years earlier for time of death. The risk factors we were able to uncover were several, including increased risks for hypertension, hypercholesterolemia, high cholesterol levels, alcohol use, and depression. These again are all risk factors that are quite amenable to treatment using a telemedicine-based system. So taking it from clinical and research perspective, we found this incredibly successful, but there was still a piece missing. The support that we could provide to caregivers, to the loved ones that were actually responsible and with the person with dementia 24/7. They need support. They're part of the care picture. And so we were very quick to initiate an educational program to provide caregivers with the tools that they need to successfully battle the disease and successfully ensure that their loved ones maintained quality of life throughout the course of the disease. That program takes the form of quarterly educational sessions that are highly interactive. They typically last an hour and a half. We are able to cover a topic in 20 minutes to a half an hour in a lecture style format, but then the remainder of the program is opened up for real life discussions of individual cases. Of course, anonymity is always requested. But we're able to address issues that caregivers have across the state. And what we find is that this is their favorite part of the program, because the issues that one caregiver is dealing with typically are reflective of the issues that many caregivers are addressing in their daily life. This program has been running now for almost 7 years and has been incredibly successful. It's an unfunded program. I'm always shocked at that, as are other folks. It is really based on the support of the telemedicine network and the local support of folks on the ground that are addressing this problem on a day-to-day basis. A staff with expertise in technology to ensure the telemedicine system is running in the remote areas, as well as a group leader, coordinator, who's typically assigned from the local Alzheimer's Association. We've since been able to expand the program, realizing that that is still only a part of the care that we can provide. Coordinating with the local physicians, training and educating the local physicians is remarkably important, and those physicians as well are limited in those remote areas to the type of educational programming they can receive. Through a grant funded by the Ohio Valley Appalachian Regional Geriatric Education Center in the federal government, we've been able to implement an ongoing, continuing medical education course that is really serving to educate and promote care and quality of life for patients with dementia, from physicians to nurses to social workers to nursing assistants and other care staff, as well as administrators at local medical facilities and skilled care facilities across the state. This really has pulled our telemedicine system from a memory disorders perspective into a comprehensive package, always keeping the patient first and foremost and assessing their needs from many different directions, providing the research needed to improve their quality of life and quality of care, providing the caregiving support and education that's so vitally needed, as well as physician and other medical staff education.